He's going to update us on chronic sinusitis. Those who have a handout, I think he's added a couple of slides to update us on a unique patient that he has in the community here. And then go ahead and launch into the rest of the presentation. Great, thanks very much.
Thank you for having me. It was actually, I really enjoyed it last time I was here. So thanks for inviting me back. That's something half decent. Before I get started, I'd like to introduce Ian Humphreys. To my left, Ian is our newest rhinologist at UW. He practices at the Medical Center and also our Eastside Specialties Clinic, which is at the intersection of 520 and 405. And he grew up in Michigan, trained at Stanford, and was a really nice guy. So we always appreciate the referrals we get from Allergy.
Yeah, he's absolutely fantastic.
And he's better than me.
Much better than Brad.
Find lunch later. So Len asked me to give an update on this guy before I launch, and you recall I or may or may not, but I did sinus surgery on this guy, Vitt. That's a very important primate. This was August of 2014 when literally he was dying of a sinus infection. They were going to euthanize him, and we did surgery, and he did well. He did well, really well. In fact, so well, he got his girlfriend pregnant. Gary, bottom right. And then in August, I got a call, and it's one of those things, I think I'm on call 365 days out of the year for the zoo now. He started holding his head and clutching his chest. He wasn't eating. He got more grumpy. And the really concerning feature was he wasn't having sex with the females. Literally, it was 7 times a day, dropped down to 2 times a day. That's really concerning. Really concerning. So the interesting thing is they thought that he might be having a cardiac problem. And gorillas over age 30, actually the most common cause of death is cardiac disease. So they said, well, does he have a sinus infection? It's like, oh, God, I don't know. Do we want to put him under anesthesia to get a CT scan? And I said, I left polyps behind last time for various reasons up along the skull base. He probably has a sinus infection. I'm surprised it's gotten this far. So let's take him to the OR. But this time, this is just checking on him. He may or may not want to go. For whatever reason, he doesn't want to go. That's him, and that's him hitting my phone. That's what he thinks of me. But I brought a bunch of friends with me this last time, and you'll recognize a couple of nice people in the crowd, and Drew's over here too. So I brought my cardiology team, our allergy team, and my ENT team, and they actually did skin testing on Vitt the gorilla. And it turns out, correct me if I'm wrong, Drew, but I believe he was allergic to dust mites, elm trees, and the big one was alfalfa. So this big guy had been sleeping on alfalfa hay, bedding his entire life. And now they removed all the alfalfa from the gorilla house. The keepers are happier because it's less dusty, and hopefully his polyps are not coming back. He's also now on Singular and Allegra, and I believe they recently started some sublingual therapy. So that was nice, and did take out some more polyps. He did have an infection. I'll show you just a couple seconds of what the inside of a gorilla nose looks like. This is 1 year after his first polyp surgery. So the tissue just looks remarkably better than it did the first time around, but he did have pus coming out of his sinuses. So he did have a sinus infection. Fortunately, it wasn't as bad, and I was able to clear out his sinuses. Those are going up into his frontals on both sides. So he did very, very well and continues to do well. And this little cutie, who they have named Yola, was born just a few months ago and is also doing well. All right, so that's the update on the big guy.
I talked to the vet last week, and he's still doing well. So.
Did the insurance deny reimbursement?
I got paid. I got 2 free tickets to the zoo. My family of 4. And then I've been invited to give several fundraiser talks and go to fundraisers. And you sit down at the fundraiser table, and now they start raising the paddle. And I can't tell you how much I've donated to the zoo since surgery. Anyway, it actually has been a life-changing experience. It's been wonderful. All right, so when Drew asked me to come back, I wanted to talk about something different than last year. Last year we focused on polyps. And this year I just wanted to give an update on two things. Here's my disclosures. I wanted to talk about recurrent acute sinusitis. This is now an ICD-10 true diagnosis, and then I wanted to talk a lot about topical therapies. And this is an interesting topic for me. It relates to the research we're doing at the UW, but it's also something that anybody can do. You just have to start doing it. We'll chat about that. So recurrent acute sinusitis, the way, this is just a nice example. Probably came from one of you, 57-year-old female. She experienced her 5th sinus infection in 1 year. It does respond to a simple course of antibiotics, and she feels really well between episodes. We did a CT scan, and on the CAT scan, you can see she actually does have some very mild sinus disease. A little bit of mucosal thickening in both of her maxillary sinuses. The osteomeatal complex is a little bit obstructed here on the right side. This is a Haller cell, this little extra sinus cell hanging off the orbit, which theoretically makes the drainage pathway of the maxillary sinus tighter and more prone for infection. So the easy question, since I've already told you what it is, what's the diagnosis? Recurrent acute rhinosinusitis. And our academy defines this as 4 or more episodes per year, separated by resolution of symptoms. That's it. Now, what do you do with these patients? And this has always been the challenge for us. I remember 5 years ago, we wouldn't do anything. We would treat them with medical therapy, make sure we were controlling their allergies, sinus irrigations, but really that was it. And then over the last year, there's been 2 good studies, in our opinion, at least, that have come out. One by Peter Wong, who was Ian's mentor at Stanford. And they took patients with recurrent acute sinusitis. They treated 77 of those medically and 104 of those surgically. And surgical therapy for recurrent acute sinusitis is really simple. It's essentially just opening up the maxillary sinuses and the anterethmoid sinuses. It takes less than an hour, pretty quick recovery, usually 2 to 3 days out of work. So not a whole lot of morbidity with it. And this graph looks at the SNOT-20, or the Sinonasal Outcomes Test. It's a symptom severity scale. The higher the scale, the worse the disease. And so up here is bad, and this is looking at 12 months out after surgery. The red line is the surgical cohort, the blue line is the medical cohort, and when you compare the two, there was a significant reduction in the sinus-related symptoms, or the SNOT-22 score, in the surgical arm compared to the medical arm. So that was pretty eye-opening for us, because a lot of people thought, it's not going to make a difference. If you're able to get better with antibiotics, why do surgery on them? Well, Tim Smith, a good friend of mine, and some other smart people, looked at productivity, and they compared the 90 days before surgery for recurrent acute sinus disease compared to the 14 months after surgery. And they also found a significant improvement in the SNOT-22 scores, so decreased sinus symptoms. And interestingly, they found a decrease in the number of antibiotics by 12 days and a decrease in lost productivity by 1 week. So patients are feeling better, they're taking less antibiotics, and they're spending less time off of work after surgery for recurrent acute sinus disease. And these are some things that are risk factors for this process. A Haller cell, which I mentioned earlier, that's this little cell that is actually inside the maxillary sinus. And it just makes this drainage pathway a little bit tighter, more prone to obstruction if that tissue swells up. It will come back, I'm sure, in 5 seconds. Concha bullosa, that's an air cell within the middle turbinate. Again, it tends to push this uncinate process lateral, making the osteomeatal complex tighter. And then finally, a deviated septum. And this is usually less of an issue, but in this case, the deviated septum is pushing over the middle turbinate, which then pushes over the uncinate process and can cause obstruction right there. So those are 3 anatomic risk factors for recurrent acute sinus disease.
Do you do anything surgically about Howler cells and concha bullosa when you operate on people?
Yes. Yeah. So if they have them, we take them out, and it's all about making that pathway more open. Allergies and cigarette smoke also risk factors for these. So we're, I send a ton of people to allergy, all throughout the region. I'm a big believer in getting people to their allergist locally in case they want to do immunotherapy. And full disclosure, Drew, his nurse shoots me every month with my immunotherapy shots. And I told him 3 years ago when we started, I'm like, this doesn't work. But I'm not going to send you any more patients. And I've had the best spring ever. It's just been amazing. So thank you.
Got lucky.
Yeah.
You want to comment on deviated septum? We see people all the time who come in being told they've had that and they think it's a big medical issue.
Isn't that amazing?
Yeah.
Oh my God, doctor, I have a deviated septum. Someone told me I had a deviated septum. My next question is, how do you breathe through your nose? Fine. Great. If it's not broken, don't fix it. And if you have an ENT that's operating on every deviated septum, that's asymptomatic beans.
Again.
Yeah. It's an easy surgery. It has low morbidity. But if it truly is, I saw a guy yesterday with a pretty bad deviated septum. He had no complaints about that whatsoever. He was there for something completely different. And I said, yeah, your septum's shifted off to one side, but that's okay. You've lived 58 years with it that way before. So yeah. Now, sometimes it is a problem. And patients with chronic sinus disease have nasal congestion anyway. And if they have a deviated septum, if it's significant, or if it's even mild, but just in the wrong spot, we have to do the septoplasty to get the instruments into the sinuses. And that is important. So some people, depending on how bad the septum is, will do a septoplasty with sinus surgery. There are times where I try to not do it, and it can lead to excess scarring if it's a really tight space. So it's not bad to do a septoplasty. And patients actually really love it. It's that whole airflow is related for power of the radius. We just make a little tiny improvement, and it's a home run. So that is nice, but it has to match up with patients' needs. So the cautionary tale is this patient who comes in with what they think is recurrent acute sinusitis, and you look at that and you say, boy, let me tell you the good news. You don't have a sinus infection. But my face hurts and I have drainage. But it's not related to an infectious process in your sinuses, and no antibiotic and no surgery is going to make that better. As opposed to this patient. These are the same, this is the same patient taken on 2 different days. The one on the left was just taken randomly by one of the outside ENTs. The one on the right, I said, she came in and saw me, she's like, yeah, I got all the sinus infections. I said, okay, I'm going to put an order in for a CT scan. When you're symptomatic, when you feel you need antibiotics, I want you to call my nurse, we'll get a CT scan that day after at least 5 to 7 days of having symptoms. It's really important to document that they actually have a sinus infection at some point in time before a surgeon considers surgery, because we don't want to operate on healthy sinuses. That's not the right thing to do. So that's my take-home message for recurrent acute sinusitis. Surgery should decrease the frequency of infections. We always caution patients, you will get a sinus infection in the future. It's part of being human. We will treat you with antibiotics when you get it, but hopefully your necessity to take antibiotics will go down.
You know that picture, you can't really see it. Go back. And you can't really tell, but on yours because of that. But like the root of that tooth is kind of pushing up into the sinus. It's because you've got that other thing blocking. So does that ever happen?
Yeah. So odontogenic causes for maxillary sinus disease is not uncommon. Some papers will say 30 to 40% of maxillary sinus disease is related to the tooth roots. And that's a good example where, sorry, I'm going off the mic, where you see the thickening just there, right above the tooth root, not in other parts of the sinus. So it's smart to look at the root, look at the apex, and see if there's any lucency there. And I tell patients I'm not a dentist, but if I see something like that, I would ask them to see their dentist and get dental x-rays. it's, that being said, I think it's still an uncommon reason to have maxillary sinus disease, but it's something important to think about, because if we just open up that sinus and it's a tooth root issue, it's not going to get better until you fix the tooth root. The amazing thing is working with one of our new oral surgeons, he reports this literature that if you just do a root canal, even on an infected tooth, that tooth will get healthy again. It gets better. Because I was sending him patients, and I was expecting the tooth to get extracted, and he would just do a root canal. And I'm like, what's going on here? He's like, no, they get better. Not a bad thing. All right, recurrent acute sinusitis. Do you guys believe it? Do surgery on it? Maybe. It's a paradigm shift. 5 years ago, we'd say no way. We'd think the surgeons that are doing that are bad people and over-operating. But we now have two good studies that show that it helps people. So it's something that should be part of the conversation at least. And if patients are only taking 1 or 2 courses of antibiotics a year, that's great. That's a good expectation. I think that's appropriate. It's if it's more than that, or if they're missing a lot of work because of it, then I think we can help them out.
Do you recall, were those 2 studies you mentioned randomized, or they were matched?
I can't recall, but I'll send both studies to Drew and he can send them out. It's a great question.
Do these patients get their immunoglobulins checked?
They get, I would say for recurrent acute sinus disease, no, in general, is the answer. And that's probably a big deficiency for otolaryngologists in general, that we are slow to check that box on the order slip and check immunoglobulins. I know in working with Matt and Drew, I will do it if someone, it's always after the fact. That's the problem with it. So it's after they've had surgery and they have repeated infections, they've been given appropriate culture-directed antibiotic therapy and they're still getting infections, and that's when we think, oh, maybe we should check for immune deficiency. And we were just talking the other day, what our success rate on referrals from Ian and I is, 20%? Maybe?
Say around 20 to 30. Yeah, a good proportion.
Which probably means we should be sending more people for analysis.
It is an indication. 2 or more sinus infections per year is an indication to check, and that's underutilized.
Even though you've got a paradigm shift, the insurance company's following behind that and saying they're going to cover this at 2 infections a year or 3 infections a year?
I have not had any pushback on this. But but I wouldn't do it I do stick to the 4 infections per year.
4 years.
Yeah. And that way then I can just relate back to our academy guidelines and say this is recurrent acute sinusitis. If I had to, I would send in the 2 studies, write the appeal letter. I have not had to yet.
What do you do with people who come in and tell you they have sinus? The word sinus, as you're well aware. And even when you get the CAT scan when they're symptomatic, it's normal.
Yeah.
Yeah, we have hundreds and thousands of those.
So I walk in and I say, I have good news for you. Let me show you your good news. And I walk in image by image through their coronal CT read format. And I tell them how lucky they are to have such healthy sinuses. And then the tears come. You're saying nothing's wrong with me. I'm saying no, something's wrong, but it's not related to an infectious or inflammatory process in their sinuses. And the way I have come to describe it is, I'd say, and you try to normalize it to some degree because people feel better if they're normalized. I say you may have had a sinus infection at some point in time, or something that caused aggravation of the trigeminal nerve that supplies a sensation to the sinuses. And that nerve flipped a switch, and it's sending a signal to the brain that something's wrong. Well, whatever caused that in the first place is now no longer there. So we need to take a shift and treat the nerve irritation or improper signal, not treat the sinus inflammation and infection. And I send at least one to 3 people per month to the neurology headache clinic at the Departmetn. And that's a good thing. I mean, my
And
best
are they
friends.
happy?
Well, no. My best friend's mother came in, and boy, the tears just were flowing. That nothing was wrong with her. So it's important to recognize and kind of justify their symptoms and saying, yes, something is wrong. The nerve's not working right. We need to take it from a neurologic, neurogenic pathway rather than sinus. And I have chosen not to treat that in my practice. That's a huge area to tackle with lots of gabapentin, Neurontin, all those things, antidepressants and anti-seizure meds, biofeedback, relaxation, acupuncture, acupressure. The neurology headache clinic does it all. Exercise, rest. I don't need to get into that. But the people that stick with it are successful. They do good work. Okay, let's talk about something fun. Topical therapies, and there's some videos in here just to wake you up too. So topical therapies for chronic sinus disease, they go from pulmicort, budesonide. I think I spoke about that last year a little bit. I'll touch up on it if we have time at the end. Mupirocin, Manuka honey. Anybody heard of Manuka honey up the sinus?
New Zealand.
We'll talk about that. Yeah, Manuka region of New Zealand is where it's from. And then my favorite, kick-ass sinus. I saw this at my grocery store and thought, I just needed that. Unbelievable. So here's a case. This is the bane of our existence. Have done very nice sinus surgery. This is looking at the right side, the maxillary sinus down there full of pus. This is the ethmoid sinuses, the sphenoid straight back. So the goal of surgery is to open up the sinuses, but even though it's open, it's still infected. And you can see this is now on the left side, very, very thick, taffy-like pus that is just not ending. And this is in clinic, just sucking out the pus. And that's what Ian and I do every day. Sometimes I go home and my daughter asks, how many noses did you pick today, Dad? I tell her enough to send her to college. So this is really frustrating. Talking about checking the immune system, this would be a great patient for that, and probably would have been a great patient before surgery. However, how do you know? And Drew has taught me over the years, if there's pulmonary infections and sinus infections, that's more of an indication that there might be something there in young adulthood and going through adulthood. But it's tough. We can't check everybody, or we could, but maybe it wouldn't be cost effective. So that would be a great lecture to me and Ian and my colleagues of when we should do immunoglobulin testing or send them to it for analysis. But that's a problem. But by opening up the sinuses, your patients will send you nice big pictures like this with a little bit of mucus. I don't know if you can see, there's no oohs and ahs with that. That's impressive if you ask me. All right, that's better. So, what do we do with these patients? And that's one scenario. The sinuses are open. We could deliver medicine there if we wanted to, as opposed to this case. This patient has recurrent nasal polyps, and nothing that we squirt in there is going to ever penetrate into a sinus. It's just going to run right down the nasopharynx and out the mouth and out the other side. So we don't have access, and in that situation, Paul and I were chatting about this before we started here. What do we do with surgery? Well, the whole idea of sinus surgery is to remove the obstruction, to make small natural openings larger, to get the bad stuff out, facilitate drainage, and to get good things in. Air, oxygen, change the pH, change the oxygen level. That probably helps a ton. Topical medications, and then facilitate our ability to remove stuff in clinic if it gets really desiccated and dried out. So the key points for inflammatory sinus disease, just a little side topic that I still tell people every day, is the day we, as in you guys, cure asthma is the same day we'll cure your chronic sinus disease. It's really true. So telling patients that surgery is not a cure, it's part of the treatment strategy for inflammatory sinus disease, has been helpful for me and my expectations, and I think it's helpful for the patients so that they understand that it is a lifelong process that we have to treat, not just the polyps. That's just the tip of the iceberg. We have to treat the root cause, the systemic inflammatory response. So a quick slide or two on sinus surgery for those of you who haven't seen it since med school. This is a gal with pretty big polyps, and this is using a microdebrider. And it's just simply removing the polyps. And that's the first step. And you can see it's not that bloody of a surgery if you do things right. Your ENT should no longer be packing the nose. If they are, they need to come to some of our lectures. So it's just a matter of removing the removing the polyps, and then finding the natural openings to the sinuses and enlarging those openings. And that's really what sinus surgery is. It takes about 1 to 2 hours, depending on the extent of disease, and patients go home the same day, unless they have comorbidities like severe sleep apnea that would require them to stay overnight. Majority of ENTs are no longer packing the nose, which is good.
How does that work? What's the mechanism of doing
So
that?
this is a shaft with a spinning blade on the end and suction, as well as some irrigation that goes through it. So
Lawnmower.
it literally sucks in, it's a rotor-rooter, it sucks in the polyp, it cuts it off, and it sucks it right down into the bucket.
Wow.
It's great. It's without this kind of 3 instruments in one, it would take us back to the 1980s when any bleeding within the sinus made sinus surgery dangerous, full of orbit trauma and skull-based trauma. And this thing can still be a devastating weapon if not used correctly. But it allows you to open up sinuses and get out pus, this thick pus, and then when you really get in there, these little nuggets of dried out inspissated pus, and you get this out. And I love having medicine residents with me when we pull this stuff out, and I turn to them and I say, do you think antibiotics would ever just magically make this stuff dissolve? And the answer is no, so there is a role for surgery sometimes. And sometimes the polyps are just a bit too big. So this poor gentleman, you can see it in the right nostril. And I started at the tip, and this is just a small piece. You can, if you look in the right nostril, it's still there. I pulled out this huge chunk, and yet it didn't look like I didn't do anything. Part of the reason why it was so big, this is looking in the contralateral nostril and the nasopharynx. The polyp is coming, wrapping all the way around the back. This is looking through his mouth and seeing the polyp hanging down from the nasopharynx. So what do? Well, I thought, let's just go through the mouth then and grab it and do what any surgeon ought to do and give it a little tug.
Oh my boy.
And that makes your Tuesday morning.
Take a break.
So he woke up very, very happy.
For a while.
Yeah, unfortunately, this was just a good old respiratory polyp. It wasn't inverting papilloma. So he did well. Case 3, this is just a classic case of, again, an open yet infected sinus. Now, here's the real challenge. This is on the right side. This is the right maxillary sinus. This is the left side. It's absolutely pristine. It's not a dental pathology on the right. It's something you need to think about. So why is one single sinus getting infected and the others aren't?
Foreign body.
Bad dreams.
Foreign body's a good thought, like if there's a screw through there or something like that. But no, the answer is I don't know. Don't know what causes that. But it is frustrating. We see it all the time. So I want to go through distribution of topical therapies. This is a paper that came out in the Rhinology literature within the past year. And I'm going to take you through this table. Sinus surgery was recommended to improve the penetration of topical therapies. So we know that if you do sinus surgery and open up the sinuses, that whatever you squirt up the nose will actually get into the sinuses. If someone has not had sinus surgery, it doesn't matter what you squirt up the nose. A squirt, a spray, a irrigation, it does not penetrate into the sinus to any real significant level. So we can't squirt gentamicin up the nose and expect it to do anything for a sinus infection if they haven't had sinus surgery. The device that is now recommended is high volume devices. Not a spray, squirt, or atomizer. High volume, like the NeilMed. I don't have any consulting relationship with NeilMed. I wish I did. But just irrigate, flooding the sinuses. Head position, head down, is with the large volume irrigation, so just vertex towards the bottom of the sink is the preferred method. Sometimes you can lay on your back and tilt your head over the bed. That's another way to do it. And then finally, unfavorable anatomy can be overcome with high volume irrigation. And that's basically if someone has really big turbinate hypertrophy, you can give them Afrin and then they can irrigate. That's one option, or nasal steroids plus irrigation, just to try to decrease that swelling if they haven't had surgery, or if the turbinates are still large after surgery. Turbinate surgery is probably something we should talk about someday. So our academy recommends for the use of a disposable high volume device. Again, the NeilMed is the easiest one. It's cheap. It's everywhere. And then we now recommend against low volume devices such as nebulizers, drops, and sprays. There was really some neat research that came out of Penn, and they used this software from the U.S. Department of Energy that looked at basically the water pressure behind a dam and the flow of water through the dam when they open and close the floodgates. So that software can measure fluid motion in a model. And they took a CT scan before and after sinus surgery and different types of sinus surgery and applied the same concept to fluid flowing into the sinuses. And they showed if you do use 240 cc's, which is the NeilMed size, you do flood all of the sinuses. If you use half a bottle, you get about 80% of the sinuses. So it's pretty interesting. It does give us more information and more data to suggest that using that is a good thing. This study they did a radiotape, a spray, and it just showed that the spray stays in the front of the nose, as you would expect, which is great for allergic rhinitis. If the turbinates are the problem, then a spray's fine. So what do we use? One of my residents, Vicki Lee, and I did this, just a really quick retrospective review looking at chronic sinus disease. And these are patients who failed oral antibiotics, and so at that point we would give them topical antibiotics as an irrigation. So we did 69 patients. Again, this was just a retrospective review to get some data for a prospective study. And after doing culture-directed antibiotic therapy in patients who had had sinus surgery, we had a 65% negative post-treatment culture result, meaning cure, basically, in 65% of patients. Still means 35% of people failed, but that was pretty good. The Len-Kennedy endoscopy scores, when we look in the nose with an endoscope and we look at crusting and polyps and inflammation and pus, and it did get significantly improved after culture-directed topical antibiotic therapy. My mentor, P.J. Wormald, down in Australia, looked specifically at mupirocin in Staph aureus patients. And in the patients who were randomized to saline irrigation, all of them, 13 out of 13 patients, had persistence of the Staph aureus after 1 month of treatment. Not a big surprise. In the mupirocin irrigated group, only 1 out of 9 were culture positive in the mupirocin, with mupirocin at 1 month. Now at 6 months, 100% returned back to being Staph aureus positive. So it's a transient improvement at this point in time. The importance of this study was a few years ago. It showed, hey, maybe topical antibiotics would help patients, and maybe we can avoid systemic therapies. So we did a randomized study and finished recruiting not too long ago. 22 patients, we randomized them to povidone iodine irrigations because, well, the reason, you guys know about the 3M povidone iodine nasal swab? Has anybody come across that? So it's a swab that is intended to use in staph-positive patients before surgery, specifically cardiac, open cardiac, and total joint surgery. It is intended to replace using mupirocin for 5 days because compliance is poor with mupirocin for 5 days. Compliance for the povidone iodine nasal swab is 100% because the nurse in the pre-op area will stick it up the nose on both sides. And so we thought that, boy, wouldn't it be fun to see if povidone iodine worked for the sinuses? So let's just irrigate with it. Randomize it to povidone iodine, mupirocin, and saline. And I'm just looking at my own slides right now. There we go. So after 1 month of treatment, we had 70% were culture negative in the mupirocin arm. These were patients who only had Staph aureus or strep. In the povidone iodine, they actually did worse, 43% cure rate versus 47% cure rate in the saline arm. But that was a significant difference.
These are people who have had surgery?
These are people who have had surgery.
And the culture's from the sinus or the nose?
The culture's from the sinus. So that means taking an endoscope with a sterile culture swab, looking at the pus pocket within the sinus and directing that either the culture swab or a sinus aspirator directly into that pocket of pus. Very different from just swabbing the front of the nose. There you're going to get Staph aureus in 30% of the people. This is really trying to get the pathogen, and only people who had a single pathogen were enrolled in this study, meaning they couldn't have normal nasal flora or polymicrobial. So this was pretty interesting and was presented recently and was well received. But still, we're getting 30% failure rate. And again, this is with oral antibiotics at the same time.
This is 5 days of mucuricin?
This is 30 days,
30 days.
at twice a day. And this is not just squirting a little bit into your saline irrigation bottle. This is 125 milligrams of mucuricin twice a day, which is a lot.
And a big Med 240 ml.
240 ml. I use a compounding pharmacy called Cascade Pharmacy that is fantastic. They compound it. If insurance doesn't cover it, then they will send the mucuricin tubes. But it's really hard to get enough mucuricin in solution. Essentially, if you squirt enough mucuricin to get the proper dose, it doesn't dissolve in the solution unless you heat it up pretty good. So you get these chunks of mucuricin, and patients don't really like that. But it is a way to get mucuricin into the nose. It's pretty good stuff. It's safe. Insurance will often cover the ointment mucuricin, not the compounded. But the compounded version is less than $100 for 1 month supply.
Do you have much trouble with anosmia? Because my old mentor used this before, and he said so many patients complained that they lost their smell that he stopped using mupirocin.
No, I don't. So this is clearly off-label, and one of our research studies in the past looked at the zinc-based Zicam, and basically our research got that off the market because it did cause anosmia. It did cause total liquefaction necrosis of the tissue. I tell patients about that story. I say this is off-label. I haven't had any problems with it, but if you notice any problems with your smell function, you should stop. I give a panel at our national meeting every year, and that's one of the cautionary tales we have, where we tell people, I don't have them sign a consent form, but everything we do is off-label. I mean, giving Bactrim for 3 weeks is off-label for chronic sinus disease. It was never FDA approved to treat chronic sinusitis. So that is an important consideration. I was a little bit more concerned with the povidone iodine for anosmia, but it was really well tolerated. We had them fill out a visual analog scale, 10 centimeter VAS, and it was just as uncomfortable as saline. So not too bad. About a 10 out of 100 on that VAS.
Greg, did you look at the resistance profiles of the 30% who failed?
No, a good question. So we at the UW do not look at mucuricin sensitivity at all. It's probably something we should ask our lab to do. In Australia and New Zealand, where the first research was done a few years ago, the resistance of Staph aureus to mucuricin has skyrocketed, and it's really concerning. But they're putting it in everybody's saline irrigation. In fact, Ernie Weimuller here for a while was having every single sinus surgery patient use mucuricin spray, and we finally had to stop that. It's just not good. One thing if they have staph, another thing if they don't even have staph. But maybe our friends in infectious disease, maybe we can work on that.
Has that been reported anywhere in the U.S.? I'm not aware of.
The
Because we use
resistance of
mucuricin a ton topically, and I haven't seen any
Not
reported
sure.
resistance to it in the U.S.
I know there are papers out of Australia about it.
It's concerning.
Let's talk about something pretty fun. So when that doesn't work, what do? I go to nature. And this is true. This is a study we're doing with Manuka honey. Manuka is a region of New Zealand. The bees aren't any special other than they live there. And there's a lot of tea trees that these bees pollinate off of. And for whatever reason, Manuka honey seems to work. In vitro it works well. It is considered a kind of biofilm buster. The biofilm is this polysaccharide matrix that surrounds the bacteria. It makes it more sticky to the host tissue and lets them group together in these large colonies, which makes it tough for antibiotics to penetrate into this big ball of pus. So Manuka attacks the biofilm in vitro and also is bactericidal at the proper dose. We got a grant through Dermascience who makes MediHoney. And MediHoney is the world's most expensive Manuka honey. For a 1-month supply, it's $700.
Tastes good.
It tastes a little sour, a little bit bitter. Yeah, it's pretty good though, but it is just a little bit on the. It's acidic. Honey's acidic by nature, so it has a little bit of an acidic taste, and maybe that's part of why it works. Is it changes the pH. But it's used quite a bit at Harborview on the burn victims. It's used at UW Medical Center for chronic wounds and ulcers, and this stuff has been gamma radiated, so there's no risk of spore or contaminants.
Is it otherwise just pure honey?
Yes. Yeah, there's nothing added to it. So we, our target enrollment's 48. This slide is a couple weeks old. I think we're up to 42 right now. And we randomized non-cystic fibrosis patients to Manuka honey versus saline. These patients also have culture-directed oral antibiotic therapy, which is a huge confounder. I mean, antibiotics work for some people, but picture, if a patient comes in, they have pus pouring out of their sinus. That's an indication to randomize into the study. I really can't ethically say, hey, let's put you on no treatment, which would be saline, versus Manuka honey. At this point, I can't do that. We have to show, you got to treat patients still. You can't just treat them as subjects, as much as we'd like to sometimes. So we randomized the non-cystic fibrosis patients. We also randomized CF patients because they're a special population. And if you look at just the CF population, this graph shows the SNOT-22 scores over here. Again, higher up is bad. And when we look at this as a clinical significant improvement level, we had a pretty interesting decrease. This is preliminary, so we don't have the power yet to make a final conclusion, but it decrease in the SNOT-22 scores. It's not statistically significant at this point in time, but the honey group is showing improvement. Looking at the post-culture positivity rate, 43% have what we would consider a cure, meaning we take a culture before treatment, then we treat them, take a culture after treatment 1 month later, 43% are cured, versus 23% cure rate in the saline group. And not a very good cure rate, pretty bad, but these are hard patients to treat. These are open sinuses full of pus. So that's a specific recalcitrant chronic sinus patient. That p-value is not significant at this point. Looking at the endoscopy score, we do see significant improvement between the honey and the saline group. And this is what it looks like. This is a patient who came in. He's had sinus surgery. This is on the left side. There's a lot of inflammation and pus through the ethmoid roof. That's inside the sphenoid. This is looking inside the maxillary sinus. That thick yellow, likely staph. This is after antibiotics, prednisone, and Manuka honey. Remember, they have had antibiotics and prednisone before and failed. So really, we're just adding the Manuka honey. Whether or not that's actually what did it, or was it oral antibiotics and prednisone that did it, but this patient is feeling much better, and their sinuses look the way we left them after surgery. So they had an infection 2 months later again. Over the phone, I called in the same antibiotics and prednisone, did not get Manuka honey, and it helped, but didn't get them as good as they were after the Manuka honey. They came back asking for more honey. Unfortunately, I couldn't give it to them because it's part of the study protocol, and you only get it enrolled once, and I can't give the $700 worth of honey out for free. There's Manuka honey out there.
The honey, dissolve it in saline in the squirt bottle?
Yes. You heat it up and then squirt it into the Neilmed.
Is there a ratio you use?
Yes, there's a proper dose to use. There's a nice dose response curve in vitro, and that's what we follow. If you give too much Manuka honey, it gets toxic. So you do have to watch out.
So when you culture these people, by the time they get to you, how many of them have gram negatives like Pseudomonas and Klebsiella and E. coli? Because obviously that's the stuff we select for when we treat these people multiple times.
So probably 30%. It's not uncommon in my practice to see Pseudomonas. That's certainly one of the top 3 most common organisms I see. Staph, strep, Pseudomonas.
And you don't change your randomization based on that. You just give them the
Yeah,
sense
so
of,
the Manuka honey is not supposed to be, it's not supposed to target one versus the other. And in fact, that's a nice segue to my next slide. So thanks. Yeah, hold on. This paper came out just last year, and they looked at sputum from cystic fibrosis patients. Specifically looked at Pseudomonas and purpurpurea, and what they did was, in vitro, they compared the killing power of tobramycin, which was pretty good, the killing power of Manuka honey independently, which was pretty good, and then they combined the two, and there was a significant synergistic response when they combined the Manuka honey with the tobramycin. So now I'm like, well, hey, there's my next grant. So maybe that's it. Maybe we have to attack the biofilm to some degree with Manuka honey and give topical antibiotics. So the combination of Manuka honey plus topical antibiotics would be certainly interesting to do.
I was just going to make a couple comments on your previous slide. If you go back to the SNOT 22, maybe you've already discussed this with the statistician, but you had two major outliers there.
Yeah.
And you already said in the beginning in the saline group, right? And that's probably driving your lack of statistical significance. And you're treating them. I don't know if you've looked at what was done to those two, whether they had some other intervention that was a major confounder.
So that is a problem. Sometimes saline people get better.
Well, but in addition to saline, you're doing other treatments.
Oral antibiotics.
So it may be that you just caught them at such a time that, you know.
And these are patients where you give antibiotics, they get better. And that happens, right? Some of our patients actually get better with antibiotics with prednisone at the time. So those two people had a good response.
Yeah, but you should probably, I mean, they're such dramatic outliers, you should somehow build that into the statistical analysis. Probably. And then for the next one, the negative, I mean, you don't really expect this to lead to negative cultures. You're just breaking up the biofilm. I mean, you're not trying to eradicate the organism as much as.
Well, we would like to.
We'd like to, but
So this is a less important. You know, our primary outcome measure is how patients feel.
Right.
The SNOT 22 score. Whether or not there's a culture positivity versus a better endoscopy score, to some degree, it doesn't matter. You know,
Right.
you care about how the patient feels. That's the most important thing. This is just simply outcome.
yeah.
And eradication, I agree. If you talk to Paul Pottinger, we don't eradicate anything.
Right.
Never.
So that seems like
It's impressive.
unfair expectation of the treatment. Is all I would say. The data actually looks, again, except for those outliers, it looks very convincing.
It's interesting. I think it's interesting to go to the next step. This is, a relatively low-funded study through industry. The real problem is it's a pain in the neck to squirt out the Manuka honey from the tube into the saline irrigation bottle. And right now, we've told the company that there is preliminary good news with the study. Could they formulate a powder version of it? My mentor, PJ Wormald, is doing a parallel study down in Australia. But they're actually adding more of the active ingredient of Manuka honey, so it's super Manuka honey. And we're going to see how the two studies compare, how they publish together.
You mentioned the biofilm issue a couple of times, and is it you think attacking the biofilm primarily, or that makes it the honey more?
I don't know if it's so if you look at the mass of Staph or Pseudomonas in vitro and you treat it with Manuka honey, it will go from a big mass into a platonic flat state.
So
And even if you have that growth on a flat petri dish and you squirt it with saline, it will lift off and wash away. So it removes that stickiness quality to it. And it's just, these photos, this video that I showed of us sucking out the pus, it's just that taffy, rubber cement type stuff. And if you can change that viscosity of the pus and allow it to drain better, I think that's half the battle. So I don't know is the answer, Mike, if it's the bactericidal property or the antibiofilm property.
I noticed that on an earlier slide, you show a bottle of Manuka honey from Queen Bee, which is a store in Madison in my neighborhood. Is that as good as the $700 a month stuff?
No. So I was going to use actually a Comvita product. They make a lot of Manuka honey, and we were going to do that until the company funded it. And then we said, well, let's just go with the most expensive stuff because it's easy. It's easy to get it through IRB, knowing that it's been gamma radiated and it's going to be safe now. The question is, will something that you can actually afford work for patients? Well, if the super expensive best stuff doesn't work, there's no point in trying the lower quality stuff.
Right.
I don't know the answer. I don't know if it works. I do recommend to some patients Manuka honey when it's the kitchen sink. We do top blend. These patients with pus-filled open sinuses, we've tested their immune system for sure. If they're still pussed out, we go to topical therapies because it just makes sense. It's an abscess cavity that now we've opened and should be able to treat.
Have any of the drug companies looked at Manuka honey and tried to figure out what the magic ingredient is there?
Yeah, it's this, I think it's called MGO, I believe. Can't recall what it stands for, but there is an active ingredient. People have taken that active ingredient and used it in vitro, and it has not been as effective as Manuka honey with it. Now, when you look at Manuka honey, like the product, the Masson product, you'll see like 15 plus or 10 plus. That reflects the active ingredient, how much there actually is. So in Australia, they're using Manuka honey like at 25 or 30 plus. They're just adding it. They can do things that we can't do. If I wanted to add the active ingredient to Manuka honey, all of a sudden it would be a drug. You'd have to go through a drug trial process. This is considered cosmetic. It's not. So I don't even have to use my investigation pharmacy to distribute this. I can just give it to people out of my clinic, which is amazing.
One other question that was typed into me by Mike Weiss back to your earlier part of your presentation. He writes here, I'd be nervous about getting a CT scan when people are sick. Refers back to a New England Journal article about abnormal CTs when people have been inoculated with rhinovirus. So in other words, the point being you get abnormal CT studies with viral upper respiratory infection.
Yeah. Mike, good question on that, and I agree. The point of the CT scan, though, is to make sure it's a sinus issue and not a nerve issue. You don't want to operate on a nerve issue, even if it's a rhinovirus, even if they're getting 4 or more rhinoviruses per year, and it's not a bacterial infection, we should make them better if we do some simple sinus surgery. All right, the last thing I want to chat about in a couple minutes is topical steroids. And this is something that a lot of you are using budesonide irrigation now, which is fantastic. This is the N of 1 study that changed my perspective. This is a patient that I had operated on, and 8 months later, he had recurrence of his polyps. This is looking at the left side. The thing straight ahead was the middle turbinate. These yellowish things are the polyps. And looking up towards the frontal sinus is polyp disease. There's this small little sphenoid disease. So he's feeling bad. He's grumpy. I'm now grumpy, and I'm feeling bad. I said, all right, let's just try this new thing. This was about 3.5 years ago. Let's try budesonide irrigations twice a day. That's all he did for 2 months. And he comes back in, smiling, happy, high-fiving, and this is it. And this is how it's supposed to look. That's the ethmoid cavity. There's the sphenoid os. Still kind of small, but it's functioning just great. And this is inside his maxillary sinus. So doing nothing else in open, previously operated sinuses, even though it looked horrible, and I was thinking for sure I was going to have to go back to surgery, he did great. So that was about 3.5 years ago, and I've written hundreds of budesonide prescriptions since then. It's really safe. It helps people. We have research that shows it helps. It does not suppress the hypothalamic pituitary adrenal axis. It does not increase intraocular pressures. So I don't use it in patients with glaucoma, but you could. I do use it in diabetics. It doesn't change blood sugars, and it does improve symptoms in both high and low tissue eosinophilic patients. That was a recent study that showed that. So it's really easy to use. Again, I go through a compounding pharmacy, and the reason I go through a compounding pharmacy is I have one line item that says budesonide 0.5 mg per 2 cc's. That's the Pulmicort dose. If not covered by insurance, then 0.6 mg per 2 cc's. That's the compounded dose. So they try to get insurance to cover it. If it doesn't, because a lot of my patients don't have asthma. Actually, that's not true. Most of them have asthma. But some patients don't have asthma, and insurance won't cover the Pulmicort when it's squirt up the nose. So then they just compound it, and it's that easy. The cash price is about $50 a month through Cascade Pharmacy.
And again, you dissolve it or have it diluted in large volume and irrigate that BID.
Right.
There's I've had people do it other ways, like just squirt it directly with a squirt bottle. I've always wondered about how much is residual if you flush it in and flush it out.
5%. It's estimated that 5% gets stays. So it's a low dose. It's actually a lower dose than cortisone. That's right. Which is probably why it's safe. But with the penetration into the sinuses, you're using all that surface area, and it's just study after study recently has shown that it is helpful. So, it's not to say that the spray. There was a study that just came out looking at nebulized budesonide, and it did okay. It was a shame that the authors chose not to look at irrigated budesonide because that's where the American Rhinological Society, we have all shifted over. There's really no one still using a nebulized or a squirt or spray version, unless the patient just can't tolerate irrigation. That's true. Last thing I want to show you is just a quick update on Propel. This is the little steroid-releasing device that we put in the nose in inflammatory sinus patients. It releases mometazone, which is lipophilic. It has a spring-like characteristic that allows it to keep the middle turbinate to the side. It comes in 2 different versions. And I'll just show you what it looks like. This is at the time of surgery, a patient with grade 2 out of 4 polyps. That's the maxillary sinus on the left. Fast forward, surgery's over. At the end of surgery, this little straw-like device, I'm squirting out the Propel right where I want it to be between the middle turbinate and the side of the nose. It springs open. It keeps that middle turbinate to the middle so that it doesn't lateralize and block the sinuses. 2 weeks post-op, when everything is swollen, including the head of the middle turbinate, you can peek your head around the corner with an endoscope and just see that little Propel in there. And even at 2 weeks, this patient was I take it out at 2 weeks usually. It's a little bit uncomfortable when it comes out, but it does
resorbable.
It does resorb, yeah. But if the sinus is crusted up, I take it out because it's really important to suction out. And usually the sinuses are a bit crusted up, so you do it to breathe in. But then I just suction out all the stuff, and that's not bad at 2 weeks. That amount of inflammation, frontal outflow tract is up top, it's wide open. I'm pretty happy with that. So it does prevent inflammation and scarring, has this level 1A evidence only because they combined 2 randomized trials for 143 patients. They found a decrease in polyps compared to the control, decrease in adhesions, and middle turbinate lateralization, which is the most common cause of sinus surgery failure. Decreased need for going back to the operating room or to get oral steroids post-op. So it's pretty good stuff. Unfortunately, it's $700 per device, and that's expensive. Yeah, it's usually covered by insurance, but actually the university just writes it off for various poor reasons. This is 6 weeks after using a Propel, and I left it in place, and it has dissolved completely. And you look at that low amount of inflammation, and if everybody healed like that, it would be fantastic. I'm just going to fast forward in the interest of time. So. A couple conclusions. Consider referring to your friendly local ENT or me or Ian for recurrent acute rhinosinusitis. If they're symptomatic and the CT scan shows some abnormalities, but it really has to show some abnormalities before I would ever consider surgery. There's many topical therapies for chronic sinus disease on the horizon, but you need open sinuses to get the medicine in there. And I'm happy to take any questions. This is my email. Oh, it's cut off. It's at uw.edu is the end. And I'm always happy to chat by email or call. And if you ever need a patient to get in quickly, just email or call me. Otherwise, if you send them through the front desk, they'll say 2 months out. But I'll always, if it's an urgent thing, I'll always make time. And thanks for inviting me today. Thank you guys very much.
Some toxicity related to Manuka honey. I guess I assume that's in vitro. Do you have a dose that you recommend patients to take? You're going to go to that health food store. How much?
Yeah, it's probably dependent on every single one, and it depends on the active ingredient. So I've calculated out the dose for a Comvita product, and I can send you, if you send me an email, I'll send you my patient handout, and that has the proper dose. I'll talk about that.
When you're in there in surgery, have you noted any differences between the different types of polyp disease, aspirin-induced or CF? I mean, do you have a distribution or size or?
So what's the difference in the polyp distribution between different diseases, CF or aspirin?
Or just ones that don't fall into those categories?
It's more, it seems time dependent. How long has it been since it had polyps out, or just the severity of disease? So I haven't really, some AERD patients, they're all bad, but sometimes just the standard nasal polyp without asthma are really, really bad too. I can't say. I always put them on preoperative steroids for 5 days, 30 milligrams of prednisone, and it helps a lot to decrease the inflammatory response temporarily and less bleeding during surgery. Thanks, everybody.
Cute.
Oh, no, he just wanted us to divvy up. Oh, he hasn't. Yeah, he has. He just, maybe he didn't see either. He seemed to have the cross-sectional side and wanted us to do the long-term side. And have you found any articles yet?
I'm sort of like looking through more general stuff to remind myself about.
Yeah, because the